Welcome everyone to today's webinar, Streamlining Emergency Department Operations with Leidos Rush University. I'm Gabrielle Mason with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. We welcome you to download today's PowerPoint slides to follow along with the presentation. The PDF is located in the Resources section of your audience console in the upper right-hand corner of your screen. Some of the detailed images in the PowerPoint deck on your screen may come across a bit blurry during today's presentation, but appear much clearer in the downloadable version. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and it will be available after the event. You can use the same link you used to log into for today's webinar to access the recording. At this time, I'm pleased to introduce our presenters and begin today's presentation. Paul E. Casey has served as Chief Medical Officer of Rush University Medical Center since June 2019. He is also a practicing emergency medicine physician, an associate professor and vice chairperson of operations since July 2017 in the Rush Department of Emergency Medicine. As Chief Medical Officer, Mr. Casey is responsible for the design, implementation, and oversight of the medical center's clinical quality, patient safety, and performance improvement initiatives. He cultivates collaborative partnerships between the academic medical practice and corporate programs, including clinical care delivery. Casey was instrumental in spearheading Rush's nationally lauded COVID-19 response strategy, rapidly mobilizing Rush for the treatment and testing of patients. As the physician director of Rush's COVID-19 Hospital Incident Command Center, he oversees clinical preparations for coronavirus cases and manages ongoing clinical operations related to the pandemic. We also have Donald Koziak, MD, MBA, FACEP, CPE, who serves as Chief Medical Officer for Leidos. He's a proven physician leader in change management and implementation of current and future healthcare trends. He's an accomplished medical thought leader, connecting patients and medical providers in unique and innovative ways, and has a diverse background with international experience. He possesses expertise in strategic market penetration, deployment of technology in medicine, and staff development with more than a decade of clinical and administrative experience directing medical facilities, teams, and staff. He continues to actively practice emergency medicine. Overall, he's a smart working, visionary physician executive with strong leadership skills and a keen ability to persuade, motivate, and influence others. As Chief Medical Officer for Leidos, he is responsible for providing clinical subject matter expertise and perspective, knowledge, experience, leadership, and direction to ensure collaboration and alignment to business strategy across the entire Leidos organization. Gentlemen, the floor is yours.
Well, thank you for that. Good morning, everyone. Good afternoon, depending on where you're dialing in. My name is Dr. Donald Koziak. I am the Chief Medical Officer at Leidos, and I'm going to start the presentation today, and then Dr. Casey and I will go back and forth in a conversational style for this lecture. Thanks for joining today. I know that a lot of you have lots of other things that you could be doing and that you see the value in streamlining the emergency department operations and frankly, the operations of the hospital. So as she mentioned in my bio, I am an emergency medicine physician. I've been practicing for almost 2 decades in the emergency department. And I know I can't really see you, but I want to do some audience participation. So just so you can play along with me, if there's anyone that's worked clinically in the emergency department, raise your hand right now, even if you're at home by yourself, if you've ever felt a little bit of burnout. And if you're raising your hand right now, you're not alone. About 1 in 2 emergency physicians and then the same number of emergency nurses have experienced burnout in the last year. And that number is only going higher as we put more operational demand and customer service demand on the emergency department teams. By the same token, if you raised your hand, I want you to raise your hand again if you've ever felt like something should have been done for your patient but couldn't because of lack of time or resources or coordination. And that number is even higher than 50%. About 75% of physicians and nursing staff that work in an emergency department would identify that they thought they should have done more, but they didn't have the time, talent, or treasure to do those things. And then last but not least, as a raise of hands, of how many of you have ever been yelled at by a patient because they waited too long or that they didn't feel like they should have waited. And that number should be almost anyone who's ever worked in an emergency department has felt the brunt of a family member or a patient not satisfied with their wait times. And so we're going to talk about in the next 40 minutes or so, what can we do to streamline operations in the emergency department that really have nothing to do with clinical care. And we want to do that, and we're going to talk a lot about focusing on things like left without being seen rates and throughput times, but we really want to talk about staff and patient satisfaction. You have to focus on things like left without being seen because for those operational leaders that want to budget against something, they really like to think about increased revenue or decreased costs. And although it's nice to say patients are more satisfied, that doesn't really go into a budget very well. So you're going to see both components of the lecture today talking about staff and patient engagement and satisfaction, as well as seeing some of those metrics that talk about that you can do some quick math calculations to see how this is a return on investment. And Dr. Casey will get into those details in a bit. So I'm going to go to the slide and say it's not surprising that nearly half of emergency departments in the United States currently have capacity issues. A lot of those capacity issues have nothing to do with the clinical care and really have not much to do with the emergency department. Could be how much volume's coming in the front door, what does the hospital look like, and what is the workflow through it. This talk today is really going to focus on what are those things that you can change and operationalize in the emergency department to maximize what you can control. And it says there the majority of patients are willing to endure 2 hours of waiting in the emergency department. But of course, that doesn't mean they're happy about waiting. And the longer that patients have as an ED length of stay, obviously it increases a safety risk for them being there. They're certainly less satisfied, both the patient and the family members. And because of that extra weight of patients, it certainly is not a provider satisfactor and can lead to some burnout and increased costs. So today our case study is going to focus around Rush University Medical Center. You know, they're an urban academic medical center seeing over 74,000 patients annually. They're not the largest emergency department in the country, but they're pretty large. They're not the biggest academic center in the world, but they're pretty focused. And so I think it's a good representation of both what a community practice and an academic medical center could look like. And what we're really focusing on for their metric is how do we reorganize their clinical workflow from an operations standpoint to see if we could impact their length of stay. And so they're going to Dr. Casey is going to take us through that in a second. You can see their numbers peaked around 4.5% left without being seen in September, and the benchmark is 1.5%. And so how can we drive closer and closer to that? So I'm going to go to the next slide and turn it over to you, Dr. Casey.
Thanks, Dr. Koziak. Appreciate it. And to echo Dr. Koziak's comments, thank you for all of those that are taking the time to tune in, as well as Becker's for the invite and the chance to share some of the work that we've really embarked upon over the past couple of years. Now, I think, you know, most in attendance are probably very familiar with emergency departments and emergency department process. And I think we all likely share, you know, in common the knowledge that emergency departments are typically very complex, dynamic environments. And there's a lot of different variables that go on any given day. Like Dr. Koziak, I'm also a practicing emergency physician, and I can tell you no two shifts are the same. When possible, really, the only variable should be those presented by patients in terms of volume and acuity. And that's really kind of been our guiding principle around this, is that the variability the patients bring in themselves is enough to be able to control for. So we should really focus on those things that we have control over. And operational improvement should really focus on those factors we can control. So you see on front of you, you know, the resources really, staff, licenses, inpatient beds, labs, imaging, those are all things that are typically moderately in control of the operators within the emergency department. And certainly there's high control over the way we design processes in queuing and waiting and how patients flow through the emergency department and the efficiencies they are in, as well as the decision-making around how patients, where they move from one place to the other, or what the ultimate disposition of those patients are. And many will also relate to this. I think it's really important to recognize that change is really difficult, but sustaining change is even more difficult. And back when I started, I've been at Rush about just over a decade now. And when I started, I had formed this emergency medicine innovations team and really in earnest pulled teams together to focus on different improvements throughout the emergency department. And we kind of broke it up. We focused some on the front end on triage. We focused some on once the patient was in a room and some of our back end processes as well. And I think we saw some really great short-term improvements and point improvements, but we realized when we looked back that often by the time we had moved on to kind of the next project and we looked in the rearview mirror, that things were just as quickly kind of crumbling from those improvements that we made. And I think this is something that, again, everyone that works in emergency department operations can probably relate to some degree. So I realized we really needed a more sustained approach to emergency department operations, and that's when we embarked on the lean journey, again, that I'm sure many of us share in common. So we recognized that really only through a value stream transformation and really baking this into our day-to-day operations and redesigning our day-to-day operations, that's the only way we were really going to be able to achieve some sustainability to our results and certainly to our operations as well. So over a period of several months, we engaged a team of all those clinicians and employees that are on the front lines of the emergency department to represent the various teams. And we went through really quite an exercise, a number of days shared together in conference rooms to apply really lean methodology and lean thinking, working through defining the problems that we saw within our operational flow, identifying the waste within our process, and then focused on both defining our future state and really building toward that future state. I think key to this was also the time we spent doing observations, in the Gembas as we went out and we observed our current processes. And then also importantly, we tested changes, so as the group was together and we thought we had created a new process, we were sure to get out there and test that change and make sure that that was the change that we wanted to continue to iterate and learn from the changes that we made over time. So I'm going to take a minute just to talk through some of the operational changes that we made, because I think this really informs then how we use technology to further enable these changes. Some may be familiar with the concept of flow cells, and flow cells are really, independent, unified teams with shared work, standards, standard work, and goals. And that was the way that we conceptualized our new operations within the emergency department. We organized our teams into flow cells, and I'll show you an example of those in just a minute. But we also really worked to staff to demand based on the utilization and made sure this is an exercise that we did regularly before and really in earnest did as we designed these new flow cells, was understanding over time the demand for the various flow cells and how we staff that flow cell to be able to meet that demand, but yet have the agility for increases in demand. Important to this work was also the service level agreements and standard work that we defined. So we needed to hold teams accountable for moving patients through the ED in a timely and efficient manner, but also make sure that those other services that work within our emergency department, whether it be lab, imaging, EKG, that respiratory, that we also had service level agreements so we could really agree to goals within those areas and then hold teams accountable for also staffing demand and also keeping track of those goals and really making those goals visible to the entire team so we knew how we were doing. Flow cells were also designed around the pull patient methodology, and I'll show, in a little bit later how that's visualized within our department. But we realized, the most efficient ways many EDs work in a push mentality of pushing patients back to rooms, but really for the best efficiency and load balancing for our teams, that we needed to pull patients on a regular cadence back into the different flow cells. And that, and on boards, as we'll also demonstrate later, really allowed us to track how well we were doing at flowing patients back into the various flow cells. We instituted the role of a flow manager that I'm sure many emergency departments also use, and that's really the individual that's charged with overseeing the movement of patients throughout the department, identifying bottlenecks, and reallocating resources where necessary to help with those bottlenecks. And then finally, and really importantly, was this near-time visibility into performance metrics. So I think many will also relate to one of the things that I found incredibly frustrating always was when we'd sit down at an operations meeting or we'd sit down, a day or a week after and look back and say, geez, last Tuesday was a real disaster. It looked like we had high left without being seen. Our patient experience scores were really poor. Our length of stay was really poor. There's nothing you can do a week later to really redesign. So you really need tools that are showing real-time performance metrics that you can flow and adjust in the moment to really make the changes that are necessary. I mentioned the flow cells that we created, and there is nothing necessarily terribly innovative outside of the design of these independent teams. Many will recognize this as the way that they split their acuities within the department. These are just a few of the flow cells we created. We also created rapid assessment flow cell and an overflow, high resource overflow flow cell, as well as a behavioral health flow cell. Those are not represented on here, but just to give you the sense, our lower acuity patients in which we knew were a high likelihood to be discharged were moved to our low acuity flow cell. We had our medium acuity flow cell that accounted for roughly 40–45% of our patients. We knew we'd require some degree of further assessment to determine acuity and plan, and the disposition was less clear. And then finally, our high resource, our high acuity flow cell into which patients we knew were likely to be admitted and would require substantial resources to be dedicated to them would move. So the ESIs are really used as guiding principles there. It is not actually the way that we are dividing patients. That helps us to think and helps as a training tool. But we may have ESI patients, 3 patients that end up in low acuity potentially, just depending again on the situation and the assessment that's done on that patient when they first come into the room. So with that, I will turn it back over to Dr. Koziak.
Yeah, and thanks everyone. I see some very great questions coming in. We're going to address those towards the end, but keep them coming. Those are some great comments. So sustainment through technology. I know everybody on this call has spent time in a boardroom or a conference room building out order sets and workflow and best practices, and you've made Visio diagrams and PowerPoints, and you've done the education, and whether it be emergency department workflow or comprehensive joint replacement or other HEDIS measures that you're trying to knock out, you've done it, you've rolled it out, and you've had immediate improvement in scores, only to be seen over the next few days to a few weeks to a few months to have it kind of trickle back up. And like a good whack-a-mole game, you're constantly having to battle what you're focusing on and trying to get that improvement. And so what we wanted to do in this case is how do we provide some sustaining technology that is different than something that we haven't mentioned yet, the electronic health record, that was able to fill in those gaps and surround the electronic health record and really focus on operational workflow and less about the clinical workflow. So the tools and technologies implemented were not around how do we get the doctors to order the exact same thing so that their length of stay is the same. We weren't addressing that, although that was addressed in places at Rush. And it wasn't about making sure the nurses all started an IV the same way or used the same thing. It was really about when those events happen, how do I know when they're supposed to happen within the time frame and the parameters in which we said is the average? And when it's outside of average, can I identify a pattern in real time in order to do that? So real time, easily to visualize and interpret, cross-functional, meaning you could be the leader of the emergency department, the frontline patient care tech, the physician in charge of the department, and bedside nurses, and everybody has sort of the same view and the same feel. And then, of course, the most important part is being agile to support continuous improvement. And by continuous improvement, I mean in near real time making changes to the software, to the tool, to reflect what's going on in the emergency department. So not the traditional, I ask a vendor to do it and it comes back 6 or 8 weeks later into a test environment, only to then have another 6 or 8 weeks before it moves into the live environment. And now for whatever reason that you thought you needed the changes, you can't even remember. And so this is where Rush and Leidos came together in a partnership. And the reason that makes sense is most of you probably have never heard of the company Leidos. It's a Fortune 250 company with 42,000 employees worldwide and $14 billion in revenue. But this isn't a commercial about Leidos. It's about the scale of which a company that would do this. And so the work that Leidos does outside of the healthcare space is around command and control operations. You see the name is an ED command center. So for the Department of Defense, if you're an Air Force aircraft and you're traveling anywhere in the world, you're likely being coordinated by a Leidos software framework in the background, getting real-time data from air traffic controllers and fuelers and targeting systems and the like, none of which ever wanted to talk to each other, and then bringing that information together and displaying on a dashboard in a single pane of glass so that an operator can make a decision about what comes next, either a commander in the field or, in this case, a physician or a nurse manager trying to decide what's next. So as you look to taking a world-class health organization like Rush, who is top in quality and expertise, and who had done a lean journey and mapped out what they wanted to do and how they wanted to do it, in a company like Leidos that is a systems integrator at heart, able to take all of that information from disparate systems and make some agile adjustments to some visualization that allows you in near real time to see what's going on in your department or in your hospital. That is where the magic came together. And so we're going to spend the next 15 minutes or so discussing the tool and then the results of implementing said tool.
Great. Thanks, Dr. Koziak. And so I will, as Dr. Koziak introduced, run you through the tools that we created to really enable flow through the emergency department. And the first of those is what we call our And-On Board. And the And-On Board really provides this live department throughput and efficiency statistics. So at a glance, a team can really get a situational assessment of their flow cell as well as others. I'll tell you, if you walk through our emergency department, you would see this presented up in all of our flow cells on a monitor. The teams can see either zeroed into the flow cell in which they work or looking at this broader, more global view of the entire department to tell how things are flowing. And I'm hoping on your screens you can kind of see some of the detail of the And-On Board, but you'll see on the left-hand side is really the different flow cells we had designed. And then you can see the action adjacent to that, or the flow through the flow cells. So we have a number that arrived within the last hour that are awaiting that flow cell. We have that's in the middle, the number waiting to get in, and then our goal within that flow cell. All of the flow cell goals are independent. You know, they all have a different goal based on the work that happens there. So that, as you'd anticipate, a patient that goes through the low resource flow cell has a shorter goal than someone that goes through the high resource flow cell. And all of those goals, of course, add up to then become the overall goal that we have for our length of stay within the emergency department. You can also, on the right-hand side, get a quick glance at the room capacity, how many rooms are currently open in the last room that was occupied by a patient. So you can really, again, get a sense of that cadence at which patients are being pulled into the various flow cells. We also designed a pitch board, and the pitch board really provides this next level down patient-specific data to make it easy to identify the constraints within the department. So here again, one has the opportunity either to look globally at the emergency department. That's typically a charge nurse or flow nurse that wants that more global view. But within a flow cell, we can also look and see, you know, again, how many are waiting, how many patients are in process of what our capacity is within that flow cell, but then the patient-specific data. So I can tell you, you know, quickly glancing at this, that labs and imaging, or imaging, seems to be a constraint that we have across multiple flow cells, and that allows us to go to our imager, our imaging suite, identify as the flow nurse or the flow manager what the constraint is there, whether it be staffing, technology, additional resources needed, and solve for that constraint in the moment, because I see it's impacting multiple flow cells across the emergency department. This is, of course, also available on a mobile device, so that has been very well received by our flow nurse role, who can rove around the emergency department and at a glance look at their devices to really see, again, where those constraints are as they're moving through the department. We also created a flow conductor tool, and again, the intended audience for this is, again, really that charge or flow nurse as well as administrators within the department. And it's a really rich, interactive visualization that allows you to, at a glance, kind of dig into what areas are behind goal, or there may be a possible constraint. So looking here, I can key in on the areas in red, and as the charge nurse or flow nurse or physician within that area, try to sort out what's holding up the disposition on that specific patient. Why are we falling outside of goal, as opposed to other areas that may be in goal? It's also important to note that this is very customizable, which we found to really be an asset. You're looking, of course, at the layout of the 60 or so beds we have within the Rush Emergency Department, but this is something that is, of course, quickly set up for other departments as well that need to use it. And I would say, importantly, it's also very flexible in terms of operational changes. So one of the frustrations we had for many years was we would make an operational change and it wouldn't necessarily be seamless to get it reflected into our EHR. Whereas on this, we were able to make some of those operational changes, flipping a room or two from one flow cell to another within a matter of hours, kind of see that change and that result as well. So importantly, I want to also discuss some of the outcomes that we realized as a result of this work. And in short, you'll see that this is something that really evolved over time, and we were challenged initially. This is kind of our pre-implementation data. So back in July of 2018 is when we embarked on the value stream transformation design. And really over that several months was the work that I mentioned, pulling teams together, understanding our flow testing changes. So in November of 2018, we first had all flow cells fully deployed, and it was through November. So early November was our first flow cell, and then we, in relatively rapid succession, because they're so closely tied together, rolled them out over a period of weeks. And in that time, we almost immediately realized some real gains. Now, I'm showing you our main outcome metric that we targeted, which was our left without being seen, and we saw that we were able to sustain that at less than 1.5%, and that translated, when we annualized it, to an additional 1,700 patients that we would be able to see and treat through the emergency department. And that, of course, caught the attention and ears of our chief medical officer at the time, as well as our chief financial officer, seeing that we had made some changes and really were able to treat additional patients, and of course that generates additional revenue. I should also mention we saw significant gains in our lower acuity, that low resource flow cell. We saw some real gains in terms of the length of stay amongst that group, and that translated to overall improvements in length of stay for our overall goal. But that seemed to be the cohort that really most benefited from the changes we had made. Now, like any change, I will say, that in the summer of 2019, we started having very high volume days, higher than we had ever experienced here, about 20% higher than we had ever experienced here during that summer. And that led to some challenges with inpatient capacity. At the same time, we were having some internal staffing challenges amongst my nursing colleagues. So that led to, a slipping from goal a little bit, but really reinvigorating the process as well. We used this time to tweak some of the tools that we had, because I would say that initial version was a prototype. and we tweaked and redeployed these tools. Now, this is moving into January of 2020 through March. Little did we know what was coming. It was February and early March that we finally had our new tools that I showed you introduced into the clinical environment. And then COVID has made it very difficult to interpret data beyond there, because we did see lower volume, increased patient complexity, and we were at target. But again, with lower volume, I wanted to see this sustain. Now, I can happily tell you that since that time, since about March, we have seen a return to normal volume within the emergency department, and still been able to sustain many of the gains that we had seen in the past. So that gives me confidence moving forward that our operational flows and the tools to support that work continue to work. I think it's also important beyond the operational data is, of course, what these tools did for staff, what they did for our patients as well. And I can tell you that it seemed when we introduced the tools and deployed them that we saw a lot of teams working better together, collaborating better together, because there was the shared operational model and really the data that was presented, on front of the screen, so they could really see where we were against goal in a very transparent way. And that seemed to foster not just more collaboration and teamwork to try to stay on goal, but also decrease the number of the interruptions. And this was from some of my physician colleagues that had mentioned, they felt prior to this, they were frequently being asked or interrupted in workflows for what's going on with, so-and-so, what are we waiting for? And now that the data was actually clearly presented in front of the entire team, that they seem to have less of interruptions within their workflow, which is always appreciated. Rush is really our brand, our reputation is as a top quality honor roll hospital. And we wanted to make sure to maintain that. So we kept a close eye on our quality, on our safety, as well as patient experience. And fortunately saw some really nice gains in patient experience as well, in spite of some of the challenges COVID presented. And I think a lot of that was from that more efficient flow of lower acuity patients as we moved away from some of the traditional flow that we had. And then the other piece that I would say that was really interesting, and this was as I transitioned roles from a vice chair of operations, involved various things, informatics in the past, as well, onto the CMO role. Once COVID struck, it was certainly an entire hospital organizational effort. But going back down to my colleagues in the emergency department, I quickly saw that they were actually using the same tools and the same operational flow and same lean thinking and lean design to develop our COVID rapid assessment flow cell. So that happened, in early March, really as we saw this impending tidal wave of cases. They used the same workflows, but they were also the tools provided us the agility to be able to really look at that flow cell, create this new flow cell, and see the operational metrics around that. And that allowed us to treat over 100 patients per day while we maintained our regular emergency department operations on top of that as well. So with that,
Dr. Casey, this is Don. I have a question for you. So when you were rolling out the system, I am assuming, and I know the answer, that Rush has a world-class electronic health record with all the fancy bells and whistles deployed and maximized. So did this tool, was it needed to enhance something different? Can you speak a little bit more about what you were finding that you needed that wasn't available in a world-class electronic health record of any brand?
Yeah, absolutely. I'll tell you, that is true. We do have one of the big EHRs implemented within our organization. And I actually worked for several years as an associate chief medical informatics officer. So really, as we were starting to embark down this road, I was very familiar with what we were able to do and tried to implement some of the same kind of thinking. And unfortunately, we hit a point, in spite of some efforts, where we realized that, while the tools are certainly useful for what they're designed for as an electronic medical record, that they didn't have that same operational and team orientation that we would need to really align with the flow cell work. So really the operational design is what dictated the need for some technology. And I should also mention, in case we have any lean black belts on the line, that we really started with, the lower tech pencil and paper approach. And then, we're able to refine that to the point that we saw, yes, this is actually something we don't want to duplicate or need to, have teams re-enter the same data in order to generate something within an EHR. We want to be able to automate this and make it easy for teams to really, respond and collaborate with the technology as opposed to it feeling like something else they need to do on top of the regular workflow.
Excellent. And in the screen where you get more patient detail, can you talk a little bit about what kinds of things you see there? It's hard to get just from, of course, the top, but how much can you dial into?
Absolutely. So, what the individual patient level data, you can really get to the level of detail. I mean, it really is the operational flow as we would think of it through an emergency department. So you can see, if I hover over an individual patient or drill down, double click into an individual patient, I'm able to see when they arrived in the department, when they were roomed, where they are in the workup, including the time our team has begun their assessment. I'm able to see if there's anything ordered from labs to medications to radiology, what's still outstanding or what's outside of goal within our service level agreements within those different areas. And then what are the remaining items that need to be completed to really take the next step in care, whether that's, disposition, including discharge or admit. So it really kind of gives you that patient journey from the minute they showed up kind of to where they are. But importantly, it's in a quick glance. So it doesn't take, multiple screens or drilling into to understand.
And that's great. The other question that I had, I'm trying to kind of gauge some from the audience, and we'll open it up from the moderator, but being a guy that's implemented a lot of stuff in clinical spaces, the clinicians in particular tend to push back when you talk to them about changing the way they practice. And I think we've talked about it already, that this isn't really looking at changing the scope or the way that they practice. It's just about, if you've ordered labs, here's the time frame, and if you have a door to doctor or a physician exam, this is when it took place. Would that be a fair assessment of how it's not directing how care is done, just that care is done?
Absolutely, and this was a critical point, I would say, in our design and discussion with our clinicians, both our APP colleagues as well as the physicians around. This is by no means redesigning the way that we see and evaluate patients. This is really just redesigning and making more efficient the work that happens around their care, so that it really, from their perspective, is really seamless. And I'll give you the example, that I realized early on shifts that, often I would be looking at the EHR and looking, for instance, waiting for a UA or waiting for a chest X-ray, and I'd say, geez, it seems like it's been a while since that was put in. But let me try to find the number. Let me call around. I can guarantee on all those phone calls when I call back, there was not that shared level of understanding around what how long it had been that this patient had been waiting for a chest X-ray or for the urine to come back. And it created a lot of extra work for both me and the team on the other side. I think not just having the service level agreements, but having that joint visibility. So, our radiology team is looking at the same board and same data as I have. They really started to, respond to those goals as well. And it cut down a lot of that rework that we were experiencing. And that's what I think really was the big buy-in for a lot of our clinicians, was they seemed to introduce a lot more efficiency and cut down some of the interruptions and kind of recreating work as well.
Right. And I know there's plenty of questions, so I think we can start answering some of them. I'll just kind of preface with like any good lean journey, when you start looking at a a particular area defined by brick and mortar square footage, you quickly learn the impacts of that right next to you, or places that impact you like lab and radiology. And so I do see some questions that have a common theme around how did you get there? And that's a whole conversation on lean and workflow. But some of them is around when you identify a bottleneck. So first of all, the question was sort of around the flow coordinator, and you have a department that's big enough to have one. What other role could do that? Is it a charge nurse? And I think that answer is yes. But when they do identify a bottleneck, let's say at lab today or in radiology, what are the things that they do in real time to help fix that, if anything? Sometimes I know they can't, but if they can you give some real live examples of what you've seen?
Yeah, absolutely. And I'll tell you that flow role is actually something that was a bit of a second iteration. You know, we did initially implement this role with a charge nurse, and then the charge nurses actually said, you know, this is of great benefit, but I feel like I'm not always focused just on that. And we saw already the gained efficiency, so we actually realized even that investment in having an extra individual would quickly pay off in terms of the efficiencies that we were realizing, which proved to be true. Now, in terms of the lab and radiology, you know, I would say it is the flow manager that's charged with those conversations. So in the example I showed, where it looked like imaging was a constraint, once they see that across flow cells, or if it's really bottlenecking or constraining a specific flow cell, they're actually physically going to radiology. We both have, you know, the ability for them to physically go there or to call the radiology supervisor on and in real time identify, you know, it looks like X-ray is backed up, or it looks like CT is backed up. I need additional help. So part of those service level agreements are not just around the goals, but also the action items that we would pull, the triggers that we would pull, so that additional resources were sent. So in our case, one of the things we do is we have some radiology techs upstairs that if we see this constraint, they're actually redeployed to help the team get back to goal in the emergency department.
Excellent example. And I guess I'll go back to that raising of the hand portion of the event. For those clinicians or in the audience, how many of you have ever done that mental math in your head of I ordered lab and x-ray and whatever, so I know I should be circling back about this time? And I know for every clinical shift I've done for the last 20 years has been trying to do that mental math of the tens, if not hundreds of patients that are flowing through the department every single day that are in my care, trying to manage those expectations, but never really having a place that does that. And my clinical practice is diverse enough that I've used multiple advanced medical records, all having emergency department boards and trackers and the like, but never really getting down to that granular level of population health inside the walls of the emergency department. What is the bottleneck that is common in all the patients? And then having the ability to step down to the individual patient and seeing what that bottleneck might be, and not having a focus on whether or not I was doing the right care per se, but whether or not my care was being done efficiently. So I think I'll pause there and turn it over to the moderator to start pitching out some questions.
Definitely. Well, thank you both so much for that presentation. And for our audience members, we're getting a lot of questions in, but we'll try to get through as many questions as we have time for, but please submit any questions you have by typing them into the Q&A box you see on your dashboard if you have not already done so. So I'm seeing a lot of questions about implementation. Could you talk a little bit about the implementation timeline and also how receptive staff was to the new process?
Yeah, well, I can take the timeline and you can take the staff.
Perfect. Yeah,
or
perfect.
You do both.
Thanks for giving me that one. No, I think it's a great question, and I'll tell you what I learned quickly in terms of the staff buy-in is that, you know, everyone working within a healthcare organization and certainly within the emergency department as well is frustrated by the same constraints they see, or the same you know, operational flow things that day after day just are like little cuts. and that really leads to a lot of the burnout, is just seeing that day after day that we're not addressing some of those things. So I really think, for staff, I think the burning platform's already there. It's really laying out the problem statement that, there's two ways we can go. We can either continue to tolerate some of the inefficiencies that we see and the things that frustrate us and, the having to call all around to sort out what's going on, or we can pull together and really try to solve for this collectively. And that our staff was really engaged in that. They were just as frustrated by the left without being seen that we had before and some of the inefficiencies that were leading to that. So I think the buy-in was really there, like all things, by involving them from the very start and making sure that at every step they were involved in the design of this process, certainly, with guardrails, but at the same time, we really had kind of a coalition by the time we rolled this out. Everyone on our staff, which is a pretty large staff, had been in the room at some point around the design. So it really became kind of a team effort on that. Do you want to take the implementation timeline?
Yeah, implementation timeline. So like anything else with technology, you can operationalize with technology a really bad process and you'll still have the same results, which is bad outcomes. And so the implementation process for learning what you do and working with people, I've been told is as little as 6 weeks, but we kind of shoot for that 90-day mark. And the 90-day mark says we really understand what you're trying to accomplish. We understand what workflows you have put into place, and then we can mirror that back in the Agile software development world, with wireframing and then building it and configuring it. There's a question on there, does the platform allow for codeless workflow? This tool is designed as a platform that's used in many different industries outside of healthcare and in healthcare. And it has this workflow builder that's really about moving widgets around and really not typing any code. And it's that modern framework. Again, I'm risking a doctor talking about the technology. So if you're interested in that deep dive, I could certainly get you some people that can go deeper down to the actual engineering charts. But the experience is about 90 days from the time of, hey, we should do this to full implementation.
Well, thank you both for those great answers. Another audience member is curious, how flexible is the ED application? Are you able to adjust the technology to new workflows, and if yes, how quickly?
And maybe again, Don, I can start with that one and then turn it to you. I would say this to the earlier conversation around some of the frustration with the HR was that often it would take a number of weeks from the time that we made an operational change and we had planned it and we had the staff. The actual constraint to that change was getting it done within the HR, and that was often a bit of a frustration because there was a lot of understandably tied in connected systems, and there had to be a lot of downstream testing and all sorts of things to understand the ramifications of very minor things such as shifting a room from one area to another. This really freed us up from that constraint. So once we had designed these, we made and tested those changes almost overnight, and that really allowed us to understand, is this change working? And if we had to flip back, our analyst within the HR would always kill me if I ever tried to flip something back. And this really, again, made it easy to flip back and forth and adjust to the flow. Because I think the reality is this is always going to be something you need to adjust. You're never going to have an ED operational style right now and layout that you're going to use 5 years from now. You always need the ability to flow and adjust.
Yeah, I think that was a great answer, and I'd just say that it's very agile. With some minimal training, you could do it yourself, or if you want someone on our staff to do it, within hours you can have a different view and a different workflow. And that's, again, using a platform design that allows you to just kind of plug and play those Lego pieces that allow you to collect the data differently or view the data differently.
Thank you both. We have a lot of great questions coming in. Another one is, how does the ED application obtain its data? Is manual entry of new data required?
So great question. No manual entry. So from quote unquote vendor side, no manual entry. So we're mapping out the data that you need to be operational in nature, and then we're pulling that from the electronic record, and then we're populating the platform to allow you to know. And again, we're trying not to replicate the EHR. We're not trying to make them have two different work streams for places that they have to go and log into to to get an idea of what's going on. And we're not trying to inform clinical workflow. So now, doctor, you should do this. It is really about the operational pieces. So you ordered a lab, and you said the standard is that the lab should be back and resulted within, let's say, 30 minutes. So I know that a lab order has gone in on patient X, and I can pull and stamp that, and I can then listen for the lab to be posted, the technical listening. And when that has happened inside the electronic health record, then I send another notice to close it out. Dr. Casey, what else would you add?
No, I would say that was actually one of really the design principles around this, was that, you know, in order to do this within the EHR, it would have taken some degree of double entry, which as a clinician, there's nothing more frustrating than knowing you're doing something just to populate tools. So really the design principle was this should be outside, this should all work from data flowing to and from the EHR, but not require anyone on the clinical staff to push extra buttons.
And the platform design is that to ingest lots of data, to normalize the data somewhat, and listen for that specific question you have, and then populate when it happens. And so again, if you think of the history of this kind of framework in the defense world, this might be a target system or aircraft flying somewhere that needs to ingest data from some satellites and things in real time, and listening for a couple key things to be happening at the same time, and then notifying the operator. Much like if you like planes, the F-35 jet has thousands of sensors on it, but one glass platform in front of it that the pilot interacts with that tells the pilot what they need to know when they need to know it, and that's the information they see. So that design concept is similar. What are the things you said you wanted to see and be notified of, and how long should it be in between those intervals, and then pushing that as a notice.
So we're seeing a lot of questions related to EHR. So another one is this interoperable with all EHRs?
Well, that's a great contract question, not a technical question. So the technical answer is yes. It's pulling data from electronic health records contractually, whether or not your specific vendor or your specific contract or your specific CIO says they would like to have that happen. We can help you to work through some of those questions. We're not writing into the electronic record, so that's a big save and usually a big hurdle to get over. If I'm entering data into my platform that will then populate the electronic health record, that tends to have a different bar than listening for noise coming outside of the electronic health records. And we can pull data from other systems outside of the electronic health record. So if you have a standalone PAC system or or lab system, or if you have, I think there was a question about EMS coming in. If you have a system that's notifying that an EMS is arriving and you want us to listen for that information and pull it into the workflow, you can certainly do that. So EHR, of course, is where 85 to 90% of the data resides, but the other 20 or 30% can be just as valuable to you to get some kind of notification and then have one pane of glass to go search for that information.
Great, thank you for that clarification. Another audience member wants to know, is the interface between the tool and the EHR bidirectional?
So again, by technical standards, I believe the interface is bidirectional. Again, you're hearing from a doctor, so I'll qualify that.
Yeah.
However, we are not writing into the electronic health record. So could I push data with the right permissions and the right contract in place? Yes, I could push data into your electronic health record. But because we are a listening tool, a workflow tool, we are only receiving in one direction at this point. Not a limitation of the platform, but by design, more of a listening and receiving than a pushing.
Okay. Sorry if that was a little repetitive. Another audience member is curious if you could elaborate on Rush's COVID response and how Leidos solution helped in providing seamless care.
Yeah, I'd be happy to take that. You know, I think so. The COVID response, as I mentioned earlier, was really, you know, it takes, as I know everyone can relate to, a really huge organizational effort. And one of my concerns as I stepped away from the emergency department to take on, you know, a bigger role in the COVID response was, you know, would we be able to sustain these operations with the challenges COVID posed? So really, again, because of the design principles that we used and the work that I talked about around flow cell design, I distinctly remember going down to see that my colleagues pulled together a group of staff, and they were really working through that same process in terms of how we would design a flow cell, you know, standing up a new flow cell, and they called it our COVID assessment flow cell. And how it would interlink to the other ones, but then also how we would know operationally how patients flowed through there. So in very short order, we were again able to not just stand up a new operational flow cell using the design principles, but also have the data to really support, you know, how many patients we're going through and the efficiencies within that.
Great. And it looks like we have time for one or two more questions. So another audience member wants to know, they said, I don't know much about measuring EDD quality, but did you have a quality check on improving flow, assurance that you didn't skim on the quality of care?
Yeah, and absolutely, you know, quality is kind of at the center of everything we do, and so we monitor that both from kind of outcomes where possible, from safety perspective, certainly through safety events as well as experience. So all of those were actually kind of control measures as we rolled out these processes. And actually, I mentioned experience was one of our outcome measures that we had used as well. And fortunately, we were able to see both the increased efficiency as well as the improved experience without any drop in our quality. And again, those are, you know, through both monitoring safety events as well as calls, you know, and follow-up work that we do and we have our residents engaged in. So fortunately, yes, absolutely, we were able to maintain and I would say elevate our quality through this work.
And then I'll add to like where next, just kind of in the wrap-up comments, perhaps. You know, this care as a service model started in the emergency department at Rush because that's where they were embracing the lean journey. Of course, they're doing that all over the hospital. And so looking at other places inside the walls of the hospital and outside the walls of the hospital that really need to have an operational focus, a command center feel to it, if you will, that can help you guide those operational steps. So you can imagine that being in a surgical department, you can imagine that being in radiology or physical therapy, or other places where there's some workflow challenges that, again, have nothing to do with data entry into the electronic health record or the way the clinical care is provided, but helping hold to the standard what you said you wanted to do and the time frame in which you wanted to accomplish those things, either because of a national quality initiative or because of internal data, and then saying this is how you did in near real time to the metrics, not 6 weeks later going to the nurse on the floor that said, remember the patient in room 2 6 weeks ago, we said we wanted to ambulate within 4 hours. You didn't do it. Tell me why. Like, how do you make a change if you're not doing it in that real time and having that kind of perspective? So I'll pause there with my, where are we going next at Rush?
Well, great. Thank you so much from both of you. That is unfortunately all the time we do have today. But again, I want to thank both Paul and Donald for their excellent presentation and Leidos for sponsoring today's webinar. And to our audience, enjoy the rest of your day, and we look forward to having you join us for future webinars.